Good evening, everyone. This is Michael Thorne. I'm here to present my capstone project titled Needle in the Haystack, Strategies to Help Optimize the Electronic Health Record to Help Address and Fight the Opioid Crisis that our country continues to face. So to start off, why did I choose this topic? I wanted to choose a real-world topic that was something that we're all enduring within our country across all different types of communities. And how it's really hasn't been addressed fully to the best extent that it could be. Also, from a professional standpoint, I chose this topic because I work as a nurse practitioner within trauma surgery. So I, day in and day out, I'm working with patients on pain control. So I see opioids around the clock when I work. Thirdly is the personal experience I've had. I had a friend, I lost a friend in 2016 to the opioid crisis. It all started with him being a motocross participant, but then also working on power lines. He developed back pain, which led to the need for opioids, and then ultimately decided to start choosing heroin for pain control and became addicted and passed away. So there's three main things as to why I decided to choose this topic, why I found it relevant related to my career and as well as from a personal standpoint. So let's talk more about the opioid crisis in the United States. In 2018, almost 70,000 people died from opioids, or at least related to the usage. We really didn't see a major increase in these opioids until the late 1990s when Purdue's pharmaceutical company introduced the OxyContin onto the market, which they advertised as being a very safe and effective way for pain control. They got one of those two statements right. It is a great way to control pain, but it is not safe and it is very highly addictive, which they said it was not. So what we saw between 1997 and 2003 was that we saw almost a 500% increase in the amount of opioids being distributed across the country. The most up-to-date data from the Health and Human Services within the United States is that about 130 people die every day from opioid overdose. And we have over 10 million people that really misuse opioids on a daily basis. So I want to specifically focus on Missouri for my patient population for my thesis. Reason being is that Missouri is the only state within the United States that has not implemented a PDMP program. In a few slides, I'll get to what that really means, but I want to address right now with my patient population. Missouri has approximately 1,100 people die a couple of years ago from opioid overdose, which puts them about 14th in the country for the amount of people that die within the state per capita. When we look at the economic numbers, specifically GDP, which is a gross domestic product, when we look at Missouri, almost 5% of their state's GDP is directly associated with opioid crisis. So they're losing about 1/20th of their state revenue to dealing with the opioid crisis. If you look over to the map on the right, you'll see that Missouri is this light pink flashlight color. That indicates that they've had an increase in the amount of opioid overdoses in their state compared with the rest of the country. They're second in the country with the highest amount of increase in relevance and rate, putting at 17%. There's only one other state that's higher than them, and that's Delaware, and that's 18%. So to get more into it, what I want to really do is address the root cause of the problem. What I found was that there's a lot of legislative disagreement. They feel that the implementation of some of these programs that I'm going to introduce infringe on the privacy of citizens within their state, and they don't want a state database that can be accessed by pretty much anyone within the federal government. Also, because they don't have a PDMP program, it's been found that they have a poor technological infrastructure that allows communication across different state hospitals and pharmacies as well. Something else that I found as being one of the root cause problems to why they haven't implemented a program is they really haven't embraced EHR interoperability, which is the electronic health record. What that really means is that the interoperability of having EHRs communicate between each other across different hospitals, that's really been a big push from the federal government with the CARES Act that was enacted a few years ago. They really want a limitation on the amount of information blocking that's going on, which EHRs tend to do to help protect their proprietary technology and their intellectual property. So my thesis statement really grinds down to whether or not integrating the clinical decision support, the electronic prescribing of controlled substances, and the prescription drug monitoring program into the electronic health record within the state of Missouri will help reduce the opioid utilization, but also abuse rates for trauma patients in the acute, post-acute pain phase, which is within 3 months following their traumatic injuries. So a prescription drug monitoring program, essentially it's an electronic database that allows permitted users to access information related to controlled substance prescriptions. So it allows a prescriber to actually see what's going on with where the patient's received medications in the past, and that will provide them with better insight as to what to prescribe, how much, or even at all if they should be getting a pain prescription. So as you can see, all these different types of entities are usually able to access the platform. So it allows a lot of collaboration across all these entities to really work together to reduce the opioid crisis. Next one is the electronic prescribing of controlled substances. Essentially, it eliminates the need for having a paper prescription, which is very important when we're trying to reduce forgery of documents and people getting their hands on opioid prescriptions when they should not actually be getting them. The third platform, which I will introduce, which is called clinical decision support. Essentially, it's a very complex computer system that provides an output of relevant information to a clinician based on a specific set of computer-based rules. So essentially, it results in the clinician being able to see the most relevant information under specific circumstances that the computer system allows. So the literature review really allowed me to really learn a lot more than what I thought I knew about all these different types of programs. I've seen a significant reduction in the amount of opioids being reduced per state, with Florida being having a reduction of 25% of opioid mortality rates, 78% reduction of opioids being prescribed in the state of New York after mandatory review by prescribers, as having the system do that. As I listed to earlier, 49 states have a PDMP program in place, but Missouri being the only one that has not been able to adopt that yet. When looking at the electronic prescribing of controlled substances, one study found that 9% of prescriptions have been linked to some sort of diversion or forgery, and that was back in 2009. That was the most relevant or the most up-to-date information I could find regarding forgery and diversion of prescription drugs. When we saw in New York's been one of the most defined and strong leaders in opioid reduction of prescriptions. They've had a 98% decrease in the amount of people who doctor shop, so essentially the ones that are out and about trying to get prescriptions amongst different doctors and within the geographical area. When we go on to looking at the clinical decision support, there's been a lot of studies been done about this. Specifically with one study showing that there was a 78% improvement with adherence to institutional guidelines, specifically for nausea and vomiting. Of course, it's not related to opioids per se, but it does show that this clinical decision support systems actually do make a big difference. Within one specific study, we saw a 22% decrease in the amount of opioids being prescribed over 22 months after implementation of a clinical decision support program that provided clinicians with alternative pain management plans. So that really did show a significant improvement. So the solution that I propose is that the state of Missouri really needs to integrate all three of these different types of programs that I just briefly went over. By implementing them all into the electronic health record, we essentially reduce clinician burnout and put everything in one user interface, so it allows ease of use, increased adherence, and increased usability. I developed, so for my recommendations, I grouped 3 different objectives within an overall umbrella term, which I called SiteOp. This is specifically directed at the state of Missouri. It's called the Statewide Informational Technology Enhancement of Opioid Prescribing. First objective was to really implement legislation that would actually allow for a PDMP program to come to fruition. This would really follow what the Cures Act is for the federal government to help ensure that we have better interoperability and communication between hospitals and pharmacies as well. I also projected to give a recommendation for a task force, which would bring everybody who has a domain expertise with pain management all together in a collective group to help provide curated resources for clinicians, but as well as patients regarding pain control and expectations for pain control. Thirdly, was capital investments. We see a lot of capital investments for digital healthcare startups in this country. The Small Business Administration, which is part of the federal government, has really pushed this as well too. Just last year, we saw over $7 billion going to healthcare startups last year, totaling it was about 532 digital healthcare startups. If the state of Missouri can implement the same type of programs that the federal government's doing, that they could essentially support local businesses, but also develop programs that would bridge the gap between EHRs, but also develop an infrastructure and as well as clinical decision support programs for these electronic health records. So my concluding remarks is that our country, but specifically the state of Missouri, really needs to take corrective action against the opioid epidemic. We kind of did it to ourselves, and it's up to us to really make a big change going forward. We have all this technology that we have at our disposal in this country, but yet we still really haven't optimized our electronic health records to make them easier to use, but then also give our clinicians the tools to provide patients with a more specific plan of care for their pain control, but then also monitor and make sure that those who are abusing, one, they can get help, and two, we can deter that from actually happening. And last but not least is we really need innovative disruption to ensure that we're keeping the pace and actually staying up to what we need to do to meet the needs of our public health system and our communities across the country. That concludes the brief overview of my thesis. Welcome any questions via email or in the online Canvas post. Thank you.